Thank you, Mama, sir. Now, I would like to call Dr. Kumar sir and Ms. Jasmine ma'am to welcome her with a floral bouquet.
Hi everybody, I'm Dr. Rajkumar. I'm pediatric department president. On behalf of Dr. Raj Gowda sir, today I'm going to discuss with you on the topic of pediatric emergency care. In this important consideration differs from the other assessment. It is not like a normal assessment when we are doing with adults. It is somewhat different from the adult. For that, you want to improve the skills and we provided the appropriate equipments like small size EV tube, small size feeding catheter, everything will be small sizes, not like other. Same like you want to know the normal values which are we are using for the pediatric age wise. According to the age 1, age 2, age 3, it is normally in age 1, what's the heart rate will be, what's the respiratory rate will be, what will be the BP, everything you want to know. Then only you know the abnormal values. I think you got it what I'm saying. Next, in this full journey, I am going to tell you how to assess the sick child. Because emergency care in pediatrics is a very broad chapter. We can't speak in one day. It will be take more than 1 week to speak about pediatric emergency care. So today we are speak more about only assessment of the emergency child. Then first, how to find a sick child? It is consists of 3R. In this, first is recognition of a sick child, and second one is the resuscitation. What you do to the child, that is resuscitation, and third one is the reference. Whatever you do resuscitation, after that you refer the patient to the higher center or tertiary center. That is the third one. After recognition of the sick child, there is two main things are there. That is called as the pediatric assessment triangle and pediatric assessment pentagon. In pediatric assessment triangle, we have three things: appearance, work of breathing, and circulation of the skin. In appearance, we have five major points that are called TICLS. It is called as TICLS. In T stands for tone, whether the baby in front of you is sick and is lying in the bed, and you are finding whether the baby is in flexed position or in extended position. That is the tone. That becomes the tone. And next one, it is the interactive. Whether the baby is interacted with you or not. It's responsive with you or not. That's the thing. Then consolable. If the baby is crying, the mother is giving the food. After giving the food also the baby is crying. That is called the persistently crying. Mainly in pediatric department, you will have the complaint, my baby is crying always. These are not the normal symptoms. When the baby cries, the mother gives the food. If the cry stops, it's normal one. If the baby cries always persistently, it is regards the meningeal symptoms. It means meningitis is there. Okay. Then look, is when we are looking for the baby, whether baby is looking to us or to the mother or to the vacant space. And then speech, whether the baby is enough grown to speak with us, orient with us, or just like that, pause, nothing speaking, weakly, or any force of voices. If any deviation in this TICLS, we have to do immediate life support interventions. Then, in breathing, several main concepts are there. Those things are apnea, tachypnea, when the heart rate is increased, it is called as tachypnea, and bradypnea, when the heart rate, when the respiratory rate is increased, it is tachypnea, when the respiratory rate is decreased, it is bradypnea. In whether any audible sounds, while the baby is breathing, even we can hear outside without auscultation. Auscultation with the stethoscope, we can hear wheeze sound or crackle sound, something we can hear. That is called as the audible sound. And regular breathing or asynchronous breathing, use of any accessory muscles. Normally, respiratory muscles is called as a diaphragm. The accessory muscles are called as a scalene muscle, sternocleidomastoid muscle, pectoralis major. Those muscles will be activated in extra force the baby is putting to breathe. Means in that case, the baby is already in the respiratory distress. That is called as the accessory muscles are already activated in the respiratory system. When we find these things, apnea, tachypnea, bradypnea, audible sounds, abnormal, irregular respiration, use of any accessory muscles, then you have to intervene. Already baby is in the respiratory distress. Okay, next. Then color. When the color is almost regarding the circulation of the skin on the system. In color, the paler color means already whitish. Baby is already pale color. In that, it's looking like whether baby anemia, hemorrhage, or any bruise. Like bruise and ecchymosis will be in the dengue. Dengue breakout is already is there. Ecchymosis and petechial hemorrhages and molting and dusky color. And other than that, cyanosis will be there and active bleeding. If any of the deviations is there in the above situation, we have to initiate the emergency intensive care. Another one, the above things we see, among them, if any deviation is there, we have to do activate the emergency response system, open the airway and establish the airway and put it on the ventilator or any other bag mask ventilation or any something else. And attach the monitor and check for the pulse. If the heart rate is less than the 60, you must start with the CPR. And assess for the IV line and secure the IV line, start with any crystalloids or IV fluids or antibiotics. Then we'll go for the primary assessment of pentagon. It consists of 5 parameters: A, B, C, D, E. A is airway, and second one is breathing, and C for circulation, and D for disability, and E for exposure. In airway, if the open airway, you can not the airway is clear, no need to do anything, unobstructed. If the open airway is clear, unobstructed. If maintainable means you have to do simple measures. If the non-maintainable means you have to do advanced measures like ET intubation. Simple measures. In simple measures, you can see like head lift, chin lift, and like helmet maneuver, back slaps, and chest thrust, oropharyngeal tube, this one nasopharyngeal airway. Those things we use in the simple measures. Advanced measures, we can use assessment, laryngeal mask, endoscope, bronchoscope, and CPAP. This one is head tilt and jaw thrust. And evaluation of the breathing. In those things, respiratory rates must be assessed by every time and work on breathing and chest wall expansion, auscultation of air entry and adventitious sound. Adventitious sound means abnormal sound like wheeze, crepitations, like pulse oximetry measurements. Okay. Normally in infants, heart rate, breathing will be around 30 to 53, And toddler means 1 to 3 year, it will be around 22 to 37. In preschool, it's around 20 to 28. In school going age, 6 to 12 years, it's around 18 to 25. Adolescents, 13 to 18, it's about 12 to 20 respiration per minute. In breathing, there is tachypnea, bradypnea, and apnea. Tachypnea when the respiratory rate is more than 60, and bradypnea when the respiratory rate is less than 10. And apnea when the baby is more than 20 seconds not breathing and just like that further to breathe. And in that condition, you can feel that extremities are cold and sinus extremities are extremely cold. Okay. Breathing, work on breathing. This is the normal condition you can see in the day-to-day life. The baby's nasal flap are enlarged and retraction will be there in the chest, brooding, head nodding, and seesaw respirations will be there. These things you can, day-to-day life, you can see in the pediatric patients. Breathing pulse oximetry. This is the usually we can carry in the pocket pulse oximetry. By this in respiratory patient easily you can assess the oxygen saturation. If SpO2 is more than 94 in room air, adequate oxygen, it is normal. Anyway, the disease is there, it is under control. If the baby is saturation SpO2 is less than 90, even though you are giving 100% oxygen, already the problem is going heavy, you must intervene heavily. And breathing identification. I am just classifying it severity and anatomical side. In severity, I am classified into respiratory distress and respiratory failure. In airway, open and maintainable, it is in respiratory distress, and respiratory failure, it is non-maintainable. And breathing, it is tachypnea and increased efforts, air increase equal. And in respiratory failure, it is marked tachypnea, bradypnea, apnea, and all air entry. In circulation, it is tachycardia and pallor. In respiratory failure, it is marked tachycardia and bradycardia and even cyanosis. And disability, the patient is more irritated, anxiated, and agitated. In respiratory failure, the patient is will be unresponsive. In exposure, like in respiratory distress, the patient will be paler, and in respiratory failure, the patient will be more cyanosis. And classified further as an anatomical signs: upper airway obstruction, lower airway obstruction, lung parenchymal disease, and disorder control of breathing. In breathing interventions, like medical upper airway obstruction will be mainly like examples of clinical probe can be treated with humidified oxygen, nebulization like budesonide, salbutamol, Budicort, something like that, and injectable steroids like hydrocortisone, something like that. And mechanical upper airway obstruction is foreign body, and we have to do Helmich maneuver, back slaps, and chest thrust. And social diphtheria, you want to give antidiphtherial ethnoglobulins. And lower airway obstruction like asthma and bronchitis can be treated with inhaled drugs. Some drugs it is of salbutamol and nilosalbutamol. Lung parenchymal disease, pneumonia can be treated with IV antibiotics. And control of breathing or coma, anticonvulsant and advanced airway, bag and mask ventilated can be done. In circulation insufficiency can be identified easily by heart rate and rhythm, peripheral and central pulses. Peripheral pulses means you can find in radial tempo, and central points like femoral artery and axillary artery you can find. And moreover, capillary refill time, skin color and temperature, blood pressure. In usually, heart rate can be usually seen in neonates is around 100 to 200. In infants is 100 to 180. Toddler is around 98 to 140. Preschool is about 4 to 5 years, 80 to 120. And school age around 6 to 12, 75 to 180. Adolescent it is around 60 to 100. In central pulses, where we can feel the pulse is carotid in older children and femoral and maxillary in the infants. And peripheral pulses are radial, temporal, and tibial. Normally, we used to check in the every baby's neonates, infants, capillary refilling time, that is called as CRT. Usually, when we do the test, 1 to 3 seconds, we want to hold the baby above the sternum, we want to hold like this. I want to say 1001, 1002, 1003, and we'll take up the fingers. In how many seconds the capillary refilling time is going on, we'll measure. Usually, normal it will happen in 1 to 3 seconds, but if the patient is going on shock, cardiogenic shock or septic shock or hypovolemic shock, the capillary refilling time will be increased. I mean, more than 3 or more than 5, around 10. See, this is one of the example. In prolonged capillary refilling time, around 10 seconds in a 3-month old in a cardiogenic shock. See, after pressing that one, about 3 seconds, it's recorded around 10 seconds. It is radiation awaiting cardiogenic shock. In circulatory insufficiency, these are decreased perfusion of oxygenation extremities. Look for the extremities, pallor, mostly cyanosis. The method of doing blood pressure by sphygmomanometer. The cuff covers around the acromial process to the olecranon about 50%, and the bladder of the BB cuff is around 70 to 80% of the midterm circumference, and hypertension can be advised by around less than 5% of the age, sex, and height. When we talk about the hypertension, the term neonates around 0 to 28 days, it's around less than 60. In infants, it is less than 70. In children 1 to 10 years, it's 70 plus age into 2. You want to call it, then only you have to know the normal values. In children more than 10, it is less than 9. And what about the urine output? In circulation, urine output is very important because indirect indicator of the adequate circulation, and it's noting as about the kidney perfusion, help to monitor the response of the treatment, how we give the treatment and how the baby respond to us. The main indicator is urine output, and for giving that process that we have to categorize the patient. That is the main thing. Many doctors, many nurses, yes, forget to when doctors used to give bolus, they just like that they give the bolus and they will not categorize the patient. Without categorize the patient, we can't assess the output. And normally, urine output normal range is 1.5 to 2 ml per kg per hour in infants. In children, it is 1 ml per kg per hour. Based on the severity, shock will be compensated shock or hypotensive shock. Based on the underlying etiology, hypovolemic, distributive, cardiogenic, and obstructive. Some of the examples. In hypovolemic shock, some of the examples are diarrhea, dehydration. Can be treated with humidified oxygen, IVSS, crystalloid dose. Destructive shock is septic shock. Humidified O2, IVSS, crystalloid bolus, antibiotics, vasoactives, and some other drugs. Cardiogenic shock is acute myocarditis, humidified O2, IVSS, and ionotropes. And obstructive shock is tension pneumothorax. You want to treat with needle thrombosynthesis. Take home message. First, pediatric assessment triangle and pediatric assessment pentagon. These two things, if you know, you can easily assess the child, whether the child is sick or not. Thank you.
Thank you, sir. Next, I would like to invite our principal ma'am, Mrs. Jasmine Sundar ma'am, to please honor the verbal moment. Ma'am, you are correctly invited on the stage. Thank you, ma'am, and thank you, sir. We must accept the end of something in order to build something new. So, before we disperse, I wish to say that it has truly been an honor to be a part of such an accomplished gathering. Thank you for making this event a memorable success. The session 1 today has been ended and another session will be continued tomorrow. That is 31st October 2023. Thank you. Thank you all for your attendance.
शिवानी मैम कह रही मम्मी जान रही कल इसी के आगे कंटिन्यू करेंगे
सर बस जाएगी ना आज
हाँ भेजा जाए